So lots of people are coming along. This is one of the meetings we do as part of the NIHR Applied Research Collaboration Northwest Coast grant, and that's a huge mouthful, I know, and there's more acronyms. As part of that, there's the MIDAS subgroup, which looks at methods. As part of that, there's the Health Economics subgroup, which looks at health economics. So that's what you're all along to today. So thank you all for coming along. I'll post in the chat, I'll post the website for MIDAS, so you can have a little look at your leisure rather than me using up Joe's valuable time and me not saying interesting things instead of her saying interesting things. So I'm going to introduce today's speaker, who is Professor Joe Coast. So you can see, oh, since at the top right, but that's all a bit random, isn't it? Worldwide. Joe's waving. Joe's the person waving at the moment. Joe is Professor of, and I'll have to get this right, Economics of Health and Care. And not just health economics, health and care, at the University of Bristol. Joe's got a huge range of interests, and she's also senior editor of Health Economics for Social Science and Medicine. But what Joe's going to be talking about today is part of her work about the theme of developing broader measures of outcome, I think, for use in economic evaluation. And that's what she's going to be generally talking about today. Looking at the Icecap, which we're very interested in terms of lots of areas, but I know lots of you are working in end-of-life care and different areas where the quality is, maybe the most appropriate thing to be using. So we have a bit of a mixed audience, Joe. There's some health economists, some non-health economists, some academics, some non-academics. The ARCs is the Northwest Coast is, I'm sure you're probably in one as well, but it's a broad church of lots of people doing lots of different things. So I can't guarantee what questions you'll get, but it'll be interesting. So over to Joe, who'll give the talk. Are you happy for people to interrupt, or do you want to wait till the end, Joe? How would you like to run it?
I'm happy for people to interrupt if there's something that they need clarifying. That's completely fine.
Okay, and if you're shy, put your question in the chat and I'll ask it. So if you're okay, Joe, I'll hand over to you and you can share your screen, and we'll talk for, I don't know, 40 minutes or so, and then have some questions. So thank you very much. Okay,
can everybody see the screen? Yeah, lovely.
Perfect.
So thank you for inviting me along. I'm going to talk about the Icecap capability measures and using them in the context of economic evaluation and decision making. And my slides aren't working. Why are they not working? We didn't get as far as testing. Oh, there we go. Okay, for some reason. I don't know what was wrong there, but it's working now. Okay, so the outline of what I'm going to talk about, I'm just going to cover the question of why capability, why might we want to measure capability as an outcome. I will think about the Icecap instruments, and I'll focus mostly on Icecap A, which is the measure for adults, but then I'll talk about the different measures across the life course. Then I'll think about whether a capability focus makes a difference, and then some final thoughts. So starting off with the question of why might we be interested in looking at capabilities in terms of economic evaluation. Well, we all know that we have to make choices in healthcare, and I think they've become more stark since the pandemic. It's become clearer that we can't necessarily do everything within the resources that we have available, and really big issues. I sit on an ICS board, and really big issues that are facing us are trying to get elective surgery back to the levels it was at before, issues around the rapid increase in demand for mental health services for children and young people, but there's a whole range of different choices that we have to make across health and care services. So the context for the UK, obviously, in terms of economics, especially in terms of making these difficult choices, is NICE. So the National Institute of Health and Care Excellence, and they talk about improving health and social care through evidence-based guidance. But I would question whether it's just really evidence, but also value that we're thinking about, and which things are the things that we want to promote or to achieve in our health and social care decision making. If you look across different decision-making organisations across the globe, you can see that not everybody uses exactly the same ways of thinking about value. Qualis is one of the main ones, but other settings use different approaches. And if we sort of think in the economics possibilities for measuring outcome, there's lots and lots of different ways that we can think about that. And I'm going to focus on the one in the bottom left, which is capabilities. So what is the capability approach? It was developed through the work of Amartya Sen, and what Sen has said is that what we shouldn't be thinking about utility, which is what economists traditionally, not necessarily health economists, but economists traditionally have focused on utility, which you can think of, if you're not an economist, as sort of satisfaction or preferences. Amartya Sen says we shouldn't focus on that, but we should focus on functionings and capabilities. So by functionings, what we mean is what an individual does or is. So are they well nourished, for example, or healthy, or respected socially, or included, or able to have independence, for example. Capabilities is what an individual is able to do or be. So whether or not they choose to do or be that thing, they have the capability to do it. So when we're thinking about capabilities, opportunities are important, even if individuals choose not to pursue those opportunities. Why? Then does Sen say we should focus on capabilities rather than functionings? So this is an example that Sen uses quite a lot in his writings. So he contrasts the position of a family that's starving with a family that's fasting. So a starving family is unable to eat because they don't have food, whereas a fasting family has chosen not to eat for religious reasons, but food is available to them if they want it. So Sen contrasts this as a way of saying that we shouldn't focus on functioning, because in terms of functioning and therefore not eating, these two families might be the same, but in terms of capabilities, they're quite different. So his position, I guess, is that he would advocate us focusing on capabilities. My own work really started with some work for older people to try to develop a measure that crossed health and social care, and that work was really trying to get attributes or dimensions for a measure. But one of the things that came up as an important theme within that qualitative work was that the older people focused particularly on capabilities. So they focused on what they could and couldn't do in life. So there's some quotes here. For example, I lost all my friends when I couldn't go out. For 7 years, I was looking after both my husband and my mother, who was beginning to go senile. I can choose what I want to do. I can choose my friends. I can choose who I want to do things with. We're fortunate in that we've got the 2 pensions. We're able to go off. We grabbed a cheapy flight at the end of April, and then for the first time in my life I'm dependent, which is not very pleasant. I can't go out as I did a few years ago, take the car and go swimming. So people talked very much in terms of capabilities, and it was that led us really to develop this new measure. The first measure that we did was for older people, but to develop this new measure in the capability context. So in terms of thinking about what the capability approach is, this is a quote from Sen, which I think is quite useful. It differs from the standard utility-based approaches in not insisting that we must value only happiness, that's the utility thing, and sees instead the state of being happy as one among several objects of value. And I think when we think about it in the health context, we've gone very much down the route, not of valuing utility actually, but of valuing health. And I think you could replace health in that quote to say we must value, not insisting that we must value only health, and sees instead the state of being healthy as one among several objects of value. So that's sort of how I see the capability approach as enabling us to go more broadly. And the question about why we should go more broadly when we're thinking about health and care, I think for me, wheelchairs is a good example of why we should go beyond just looking at health. So a wheelchair doesn't improve somebody's health at all, but what it does massively is improve their capabilities. So we can think about capabilities as an alternative evaluative space for economic evaluation. So imagine we have a good that we're thinking about trying to evaluate, hospice provision. So when we do economic evaluation, as well as thinking about all the costs that go into the input side, we have to think about what it is that we want to measure on the output side. So what is our evaluative space? So as I've said, the traditional evaluative space for economics is utility, so that this focus on pleasure. So we might think about that in hospice terms as the satisfaction or the pleasure that we get from receiving care through the hospice. The standard approach within health economics is to focus on health. So there, if we were going to evaluate hospice provision, we'd be thinking about improvements in morbidity and mortality. Capabilities provides us with a third alternative, where what we'd be focusing on is what somebody is able to do or be in their lives. So again, in terms of thinking about hospice provision, that might be about things like the ability to make choices about your care, or the ability to make preparations for the end of life, and so on. So that gives you a little bit of a background in terms of the sort of theoretical aspects of capabilities. In terms of how might we go about measuring capabilities, that's really what the work around Icecap has focused on. So I'm going to talk you through in a bit more detail the Icecap A measure for adults, both in terms of what's in it and how we got to it. And then I'll give you a slightly briefer introduction to the other measures sort of within the Icecap family of instruments. So what are these Icecap measures? So they're measures of capability well-being, so they explicitly focus on what people are able to do and be in their lives. In terms of how they've developed, they've drawn on some of the lessons from the QALY approach. So like sort of EQ5D, and QALY is generated from EQ5D, they're based on a number of dimensions. And in the same way, we try and measure or value the attributes in a meaningful way. So by that, what I mean by that is that the scores that we give to the items in some way reflect how the population values those scores. But they differ in important ways from the QALY approach. So first of all, they're based on what people themselves feel is important. So they aren't based on sort of reviews of the literature. They're not based on philosophical ideas, which is often used within the capability approach to determine what things we might be interested in looking at. They're not based on existing measures. They're based on qualitative work. And they also differ in that they are anchored in a different way from QALYs. So a QALY is anchored on full health and death. These measures are anchored on full capability and no capability, and that has implications then for how we use them in decision making, and what we can do with them, and how we interpret what we get from the measures. So in terms of developing these measures, all the different versions have been developed in largely the same way. So they've all had a first phase of in-depth interviews to generate the conceptual attributes, and most of them have been analysed using constant comparative methods. They've all had a second phase of semi-structured interviews, which have focused on making sure we've got the right attributes within the measure, but then particularly on making sure that the wording that we have within the measure reflects those original conceptual attributes. Then they've all had a phase 3, which is around valuation, and most but not all of them have used best worst scaling with the general population. And then there's a sort of fourth ongoing phase for each measure, which is around assessing its use in practice. So the sort of measurement properties of the instruments. So looking at things like, is the measure acceptable? Is it valid? Is it reliable? Can it pick up change? So just to explore the phases of the development of the measures in a bit more depth. So this is basically the process we've used for all the measures. So a very sort of circular, iterative process for developing the conceptual attributes. So in-depth interviews to find out what's important to the informants. analysis of those interviews, thinking about whether from that stage of interviews the conceptual attributes are fully defined, and if they are, then you can move on to the second stage, but if they're not, it's about then identifying issues for further exploration. So the Icecap A was based on interviews with 36 informants in 2009, lasting around an hour to an hour and a half on the whole. In terms of how we get to the attributes, I think especially for people who don't do qualitative research, it's hard sometimes to see how you get from those very long transcripts to essentially something that's quite reductive in terms of the attributes for a measure. So I just wanted to sort of talk through how we did that and how we ended up with the attributes that we did. So this is an example of quotes that were all about health. So my health broke down again, it cast a long shadow. You don't know when it might jump on you, so you live with uncertainty. Obviously, its mother's illness has been hard, it's been upsetting, and visiting her now isn't exactly a barrel full of laughs. I guess it's saddening. You feel ill, you feel you can't achieve anything, and I think it makes you feel that you're a failure. Depression mainly means just come in, shut the door, go to bed, don't go out, don't see people, don't socialise. So each of those quotes is about health, but actually they're all about different things. So the first one is really about stability and not having uncertainty in your life. The second is about enjoyment. The third is about achievement. And the fourth is about having the ability to have attachment with people. So from all this qualitative work for the Icecap A, we ended up with 5 conceptual attributes. So those were around stability, which was about having a sense of continuity in your life, not living with uncertainty, feeling settled. The second one's around attachment, which is about having love and support, having social contact and affection, being close to people, belonging. The third attribute was autonomy, which is around being able to be independent and to make your own decisions, being free to be yourself. Achievement, being able to move forward in life, being able to attain your goals and be recognised and satisfied with that. And the final one was around enjoyment, which is both the sort of fun and excitement in life, but also the sort of quiet pleasures that people have. So we had those 5 conceptual attributes for the Icecap A, and then we did the second phase of the work, which was around getting the meaningful wording for these attributes. So really by meaningful wording, what I'm trying to get at is wording that evokes those conceptual attributes for people who are completing the measure. So we started off with sort of brainstorming of terms and drawing those from the original transcripts, then doing interviews to ask people what those terms meant to them, analysing the interviews, and then working out if we'd got the terminology right or not for that. And that led us then to our description of our 5 attributes. So the way that these are worded within the measure: stability becomes being able to feel settled and secure. Attachment is about being able to have love, friendship and support. Autonomy about being able to be independent. Achievement about being able to achieve and progress. And enjoyment being able to have enjoyment and pleasure. Then the next phase is to move on to valuation. And here, one of the challenges that we've had has been trying to fit in with, I guess, what is useful for economics and for decision making, but also not to go too far against what's recommended within the broader capability approach. So Sen himself rejects the use of individual choices or individual desires to value capabilities, and that's because of a concern with adaptation, which is basically the idea that if you're in a poor state for a long time, you might see your state as being better than you would if you hadn't been in that state for a long time, and therefore that might lead you to not value an improvement in health for people who show these adaptive preferences. So Sen suggests other options. So suggests deliberation and debate as a way of getting at values, but it's not at all clear how you would do that. And Richard Cookson, who's a health economist at York, back in 2005 suggested that what we could do is use the sorts of things that we do in QALYs to elicit from the population values which can be considered as evidence for values in Sen's approach. So what we have done is used best worst scaling in combination with discrete choice modelling as a way of trying to do that, to use that sort of Cookson's compromise approach. And best worst scaling we chose because respondents are only asked to specify which attribute levels they think are the best and the worst when you do this type of valuation task. And therefore it's slightly different from the sorts of approaches that are more used in QALYs, where people are asked to trade one thing against another. So it felt to us that this sort of best worst scaling approach might come closer to eliciting the sort of values that Sen talks about, rather than the very sort of trade-off type values. So this is an example of the sort of scenario that people were faced with in the valuation task. So basically you have each attribute in there, and you have a level of each attribute, and you ask people to say which of the items is best and which is worst, and from that you can generate a set of values by doing this across different scenarios with your population. Having got values, then there's a choice to make about anchoring, and there are a number of choices available. So anchoring is important for economic evaluation or in the QALY approach, because what it allows you to do is to with a large number of quite strict assumptions, but what it allows you to do is to equate states of quality of life with length of life. So it allows you to multiply up periods in different health states and add them together to get a total measure of benefit. So the question for us when we were starting off with this, developing this measure, is should we do that, and if so, how should we do that? So the choices that we had were to not anchor and just say actually capabilities are incommensurate with life. And in many ways that's sort of what happens with many of the capability uses outside of sort of health economic evaluation. We could anchor on full capability and no capability. So if we do that, what we're doing is saying that we're looking at a measure of capability over time, and the way we deal with death is by making a sort of philosophical assumption that being dead is equivalent to having no capability on any attribute, which is not the same as saying that no capability on attribute and any attribute is the same as being dead. So it's a slightly different assumption from the assumption we make in QALYs. We could have anchored on full capability in death, which is what's done in QALYs, or we could establish anchors via discussion and debate. And what we did was we went with the second option, which affects how we can interpret what we do in our decision making, and I'll come back to that in a moment or two. So the Icecap A, this is just to show you what the instrument looks like. It's very simple in terms of implementing it in a study. It's a bit like putting in the EQ5D. It's 5 questions, it's on 1 page. There are 4 possible responses for each item, and this just shows you the values that were developed from the general population. So what you can see here is that the difference between having a lot of capability and having full capability is not that high. That there's more weight given to shifts from having no capability to a little capability, and from having a little capability to a lot of capability. In terms of evidence for the use of the measure, so Afen-Tu and Phil Kinghorn at Birmingham did a systematic review in 2019, and what they found were that there were good levels of content validity for the measure, They looked at associations between Icecap A and socioeconomic indicators, attitude, perceptions of freedom, and so on. They looked at associations between Icecap A and other measures used in this sort of space, found that there were fairly consistently strong associations with Icecap A and A equal 8D, which is unsurprising. That's an Australian measure that has, I guess, more focus on well-being than the standard measures within that we use more in the UK. The association was less strong with EQ5D. And there has been an empirical distinction found between functioning and capability. So basically, if you ask the questions in terms of, are you able to do these things, you get different answers from do you do these things. So actually that distinction between functioning and capability does matter in terms of when we are measuring these sorts of outcomes. They also looked at sensitivity to change. They found that, as you'd expect with a generic measure, the Icecap A was not as sensitive as some condition-specific measures, but that it's similar, I guess, in terms of the EQ5D, which is sort of what you'd expect because you're measuring at a much higher level of generality. In terms of how we can use Icecap A in decision making, as I've said, it's similar to QALYs, but the anchoring makes it conceptually different. So what we've talked about is analysing in terms of years of full capability gain, so equivalent years of capability. There is an alternative option that we've also worked on, which really focuses on the people who are in the bottom of the measure. So analysing in terms of years of sufficient capability gain. So there, what we're concerned with is only really giving our resources to those people who have an absolute shortfall in capability. In terms of the use of the measure in practice, and again drawing on this systematic review, what they found was that for some circumstances there was an indication that you would prioritise different things if you shifted to capability, well-being, and away from health functioning. And what they said was that because capability well-being offers a broader set of outcomes, it can be considered more appropriate for use in economic evaluations of public health and social care. So that's the Icecap A. I just wanted then to introduce the other Icecap instruments. And what we've done in terms of thinking about Icecap is to think very explicitly in terms of the life course and the potential need for different measures at different parts of the life course. So actually the very first measure that we developed was the Icecap A, which was the measure for older age. So that basically drew on qualitative interviews with people aged 65 and over, and the valuation set is also from people aged 65 and over. So this is the Icecap O. You can see it's quite similar to the Icecap A. It has 5 attributes, and they cover, I would say, a broadly similar space, but they are slightly different. So the 3 that are most similar are love and friendship, enjoyment and pleasure, and independence, which largely mirror the Icecap A. The 2 that are a bit different are what is stability in the Icecap A is security in the Icecap O, because people talked a lot about being concerned about what would happen to them if their health failed or if their finances were poorer going into the future. So that became thinking about the future without concern. And then the other one that was quite different was in the younger population, achievement came out as, or in the whole adult population, achievement came out as important. But for the older people, they often say things like, well, I've done all my achieving, and then it becomes more about a role and having a purpose in life and doing things that make you feel valued. These are the values for the Icecap O, and you can see that they're quite similar in that, again, for most of these attributes, the difference between a lot of capability and full capability is relatively small, with much more of a difference at the bottom end of the scale. In terms of end of life, we've developed 2 measures. So one is the Caf Supportive Care measure, which is for people who are at the end of life, and the second is the Icecap Close Person measure, which is a sort of companion measure because of the importance of interventions at end of life, focusing not just on the person, but also on the people around them. So we have this companion measure, the Icecap close person measure. So this is the Icecap supportive care measure. You can see that this is looks a little bit different. It's got 7 attributes, still got 4 levels for each attribute, but it's got seven attributes. And if we look at those in a little bit more detail, we can see that they aren't quite the same as the attributes in the other 2 measures that we've already looked at. So one difference is that there are 2 attributes that focus more explicitly on health. There are 2 attributes that focus more explicitly on care, and then there are 3 more general attributes, with a couple of those really quite closely again mirroring the Icecap A/Icecap O attributes. If we look at the valuations, though, I think this is quite interesting. So again, you can see the sort of the values for the different levels of each of the attributes. But what you can see is that the 2 health attributes really only take up quite a small part of the space of the total value. So between them, they add up to about 15% of the sort of valuation space, whereas the care attributes add up to about 40% of that space. So I think that's quite interesting in terms of thinking about what people value for end of life, in terms of that sort of health versus care dichotomy. The close person measure, this was developed by a PhD student, Alistair Canaway, and he developed this measure for close persons, so this sort of companionship measure. And what came out as important in those interviews was around communication with those providing care services, privacy and space, practical support, emotional support, preparation and coping, and emotional distress. And this just gives you an example of how this measure is worded. So there's some examples that are used to make it clear what's being talked about, and it's got the 6 items across the couple of pages. And the value work for this is the only one that's used a slightly different approach. So we actually did the valuation for this within sort of focus group settings, where people had a chance to discuss their thinking around this, and it used a slightly different approach to the valuation. So I suppose I'd probably see this as a more exploratory value set, in that it's on a relatively small number of people, and probably not really a sort of full representation of the general population, but it does give us a chance to use that sort of more deliberative approach. And here the 2 that are most important are the communication and practical support elements. The work that we're doing at the moment is trying to extend this sort of way of thinking into children and young people, and we're developing measures for children and young people within different age groups. So we're again doing direct research with children and young people, and looking at both well-being and their sort of well-becoming into the future. And we've done that again with the same sort of approach, but our phase 1 interviews were conducted with both children and young people themselves and parents. So for ages 6 to 18, we spoke to the child and the young person, and for ages 0 to 15, we also talked exclusively to parents. And for the interviews with children and young people, we used a task to encourage engagement. So we used this sort of what's called hierarchical mapping approach, where we got the child or young person to take a photo of themselves and put it in the middle, and then they wrote on post-it notes the things that were important to them. And that was all done before the interview. So it was really about trying to make the young person feel engaged with the research, make them feel comfortable before we sort of turned on tape recorders, and also then it gave them a prompt to use within the interview itself. So it worked really quite well, I think. We've got 2 measures that are finalised but not yet published. So a measure for the 11 to 15s with 8 attributes and a measure for 6 to 11s with 7 attributes. There are some differences compared to the adult measures. One thing that really came out strongly was for children and young people themselves was around the ability to learn and experience new things. It came out much more strongly in the child themselves rather than the adult interviews, and we don't have it in any of our adult measures. So I think that's really quite interesting. Also, an attribute that encompasses the developing identity, particularly for the older children / young people. And then also these ideas about well-becoming and thinking about your future, so aspiration. And then in the second phase, what we did that was different was think about visuals to aid completion of the measure. So I'm going to talk about that because it's quite interesting. So we tested a number of different formats to try and include visuals in the measure that would help the children or young people who are completing the measure to have a good sense about what they were being asked. So we tried all these different approaches. So one was around just presenting the measure in the same way as we had in all the adult measures. We used what we call cups, but they often thought of as batteries in so the little boxes in the bottom left corner. We tried a plant growing, and so starting from a seed and then growing. We tried faces and we tried ladders as ways of trying to sort of visually show the different levels of the attributes. So the first one, they thought it was boring and like doing an exam, so that seemed to go out pretty quickly. We found that the ladders they didn't really get, and they didn't feel that it helped. I think possibly because they're only relevant, they're only useful in relation to each other rather than more in an absolute way. The plants, some of them liked the plants, some of them didn't like the plants and thought they were a bit depressing or not very clear. And then we were left with the faces and the cups. So both of those the children and young people tended to like. But the faces was interesting because some of our young people noticed that, or noted that, the faces really show how you feel about the capability rather than what the level of the capability is. And we also had similar feedback from a capability researcher along those lines. So what we ended up with is the cups. So that's how we've tried to show in a visual way the different attributes. So just to give you a very sort of quick peek at the measures. So what you can see here is the secondary and primary measures, and the secondary measure you can see has a little bit more text on it than the primary measure. So just to sort of come towards the end of the talk, if we use capabilities, does it actually make a difference to what we might find compared to if we use health? And I've just got a couple of thoughts really to share. So this is some data from the MIC work that Jeff Richardson did in, well, he did it in a number of countries, but he led it from Australia. What you can see here is the scores on the Icecap A for different groups within the population. So there's a sort of healthy public on the one end, and then a number of different conditions, and the Icecap A is in blue and the EQ5D is in red. And it's not, you don't need to think about the absolute levels of the scores because they're on different scales. It's about the relativities that I think is interesting here. So if you look at the healthy public, they look similar in terms of the sort of levels of the scores. If you start to look at the conditions, you can see that there are some interesting differences. So arthritis, for example, results in quite a big drop in health, but the drop in capability is not so severe. Whereas for depression, you have a similar sort of drop in health to that of arthritis as measured by EQ5D, but a much larger drop in capabilities. So what that tells you is that if you use this measure, then how you prioritize across different health conditions might differ. The other area we've been thinking a little bit about the sort of use of capabilities is in the context of COVID-19, and whether, if we're thinking about interventions in this sort of context, when we're thinking about things like lockdowns, is it helpful to think about broader outcomes than just health? Because obviously, you know, I didn't have COVID until the very, very end of the pandemic, so my health didn't change in the pandemic, but because of all the lockdowns, my capabilities did change. And capabilities change for all sorts of reasons. Capabilities change because people did have COVID or long-term sequelae from COVID, but people also lost their jobs. People missed out on treatment for other conditions. So I suppose the question really is whether capabilities can provide a useful analytic framework for decision making. Similar issues at the end of the life course, we all saw the difficult trade-offs in care homes between attributes around people's health versus things like people wanting to be with their relatives in care homes, and that people felt isolated in care homes, and something like Icecap might help you to see how those different things are valued within your population. So this is just some work that we did around the drop-in scores compared to pre-pandemic. So you can really see that at the very beginning of the pandemic, there was quite a big drop in capabilities. This is across the population as a whole, and that had recovered somewhat a year into the pandemic. So moving forward, just finally, a couple of slides. The measures, they're included in more than 300 studies globally. There's a lot of ongoing assessment across the different measures, quite a lot of translation as well. Something I haven't talked about actually is that we're also developing from scratch a measure for Malawi and Tanzania. So there was some very preliminary work done by a group which found that some of the attributes didn't work at all well in that context. So we've actually done the whole development process for Malawi and Tanzania as well. And that's sort of being written up at the moment. In terms of the children and young people work, so we have these descriptive systems for the 6 to 11 and the 11 to 15, and at the moment we are analysing data that we have already collected around valuation and validation for the 11 to 15 measure, and for the 6 to 11 measure we're in the process of data collection, and what we're doing there is the valuation with parents, but the valuation with parents, but the validity assessment with children and young people aged 8 and above, and parents as proxies for the younger children. For the older children, they've done the validity and the valuation themselves. And then we're still working on the development of measures in the 0 to 5 and the 16 plus age ranges. One other thing just to say, one other piece of work that's also ongoing is a PhD student of mine, Isabella Floridin, has been doing qualitative work to develop attributes for a measure for young people aged 14 to 25 living with life-limiting and life-threatening conditions. Because of the pandemic, she had to do all of her work online, and it's ended up that she's really got to the point of having the conceptual attributes but not doing the work beyond that to turn it into a measure. But again, that's interesting in that the attributes cross the sorts of things within the CYP measure and those in the supportive care measure, which is more was developed with older people at the end of life, I guess. So that's all I've got to say. There's lots of papers out there if you're interested. The website actually has moved from Birmingham to Bristol as of about 2 months ago, and we also have a Twitter account. So I will stop sharing. If that's
Thank you very much, Jo. That's fantastic. If people can turn their cameras on now, if they so wish, and please raise your hand if you want to ask a question, or just ask a question or type it in the chat. So I've got some questions, but off you go if you're not me. Catherine.
Right, I am clearly not a health economist. I think Jo knows that. But what is your thinking about using these measures when it is not part of a health economic evaluation? In other words, the sort of concepts that you've been talking about and the questions that are being asked are quite broadly allied and often in a much more appropriate way, I personally think, to some of the other non-economic measures that we might use. So I guess my question is, do you see these purely as health economic measures, or actually are they being, or could they be used more generally as outcome measures of some form?
Yeah, there's no reason they couldn't be used as outcome measures. I guess because they were developed as measures for economic evaluation, I guess when we developed them, we followed the sorts of restrictions that are sort of imposed, I guess, on economic measures, particularly around the ability to do the valuation, which means that there aren't loads of questions. So from that perspective, they look like an economic measure, but there's no reason you couldn't use them more broadly. And I think they have been used by non-economists who've been interested in the concepts and the attributes that they provide. I mean, it's been interesting, actually. It was a long time ago, but somebody contacted me from a health authority or setting in Scotland, and they had been using them in a hospice to actually generate discussion, and they'd found that actually it opened up people's ability to talk about certain things because they were being asked these questions. So they almost used it as a prompt for discussion rather than at all in an evaluative context. So I think you can use them in other ways. You just have to be careful that because they were developed with this specific purpose in mind, that they're validated and assessed for the purpose that you want to use them for, that is different for what they were generated for. And I'm glad you're young and see it as a battery, Catherine.
My questions were really about the policy side of things a little bit more. You know, we know NICE like things done in a certain way, and other organisations around the world like things done in a certain way. How are you finding people, you know, on the policy side are reacting when you're coming along and saying, actually, that's maybe the EQ5D is okay for certain things, but actually when you're looking at care, or, you know, carers, I noticed that we do some work about carers during lockdown, for example, and we didn't have a way of measuring, well, we didn't think we did, sorry, of measuring it was secondary data, so measuring outcomes for carers. So how are you finding the general reception of are people grabbing at it and saying, actually, when we're looking at making resource decisions in social care, we do need something new?
So when we first started sort of presenting especially because it was Icecap and it was specifically focused on, I mean, its original reason for being developed was around being able to cross health and social care, and Ski at the time, was it Ski, were quite interested and took it up, and it is in the NICE guidance around social care that you can use Icecap measures. It's also in the Netherlands guidance around long-term care that you can use it, but the extent to which it's actually used, I don't know. And I mean, you know, I sort of look at I don't know what the correct word, the debacle over the shift even in changing the values for EQ5D and the absolute stress that seems to have caused, makes me think that there is it's almost like a sort of lock-in on policy that having made a decision to use a particular measure, there's a real reluctance to change, which I think is quite damaging and dangerous, because that originally EQ5D was developed so long ago and is so really out of date. And there's a lot of thinking. I mean, and I think there's a more general push to think about. I mean, we started developing these back in 2004, 2005. But I mean, with the whole sort of Euroqual shift towards thinking about well-being, I think they're going to have to be a bit more open about how they do this going forward.
I think so. Oh, sorry, Stephen Mason, hand up in the corner. Sorry, my apologies.
I'm sorry, it's my colleague Anne that's asked a question. Yeah, thank you for your presentation. It was really interesting. I just wanted to ask a question, and maybe this isn't relevant, but in your measurements, so you talked about sort of measures of capability, well-being, and what people potentially can do. And then you just talked there a little bit at the end about restrictions that are imposed upon them. Did anything within your data or potentially link it to obviously the waiting list that people have in terms of hospital appointments, cancer treatment, you know, did anything come out on that sort of about how that links to the wider picture in terms of access to care and interventions that may actually make them more capable than they are? That makes sense.
Yes. So I'm just trying to think back. So are you talking about the COVID data or just more generally the quality?
Just generally, I mean, it's just,
yeah.
I don't know, I'm just thinking there was a on Five Live this morning about people's cancer treatment being delayed. So, you know, and how that imposed on their day-to-day lives.
Yeah, so the work for Icecap and Icecap was a while ago, but people I wouldn't say there was a huge amount in terms of treatment, but especially I'm just thinking about the older people interviews. People talked about sort of health conditions that they had and how that affected their daily life. So I don't think people talked so much about access to services. I tell you where they have talked about access to services actually is Isabella's PhD work around the young people with life-limiting conditions and life-threatening conditions. There's a lot in her interviews which were conducted over COVID. There's a lot in her interviews about the lack of access to services and how that has impacted on people's capabilities, and that services including health and social care, but also sort of education and so on. So there's a lot in her interviews about that, probably more than most of the others, I would say.
I noticed in the carers one, there was maybe a lot of information about communication, and maybe that's kind of an access issue as well. I guess that's communication with social care side of government, rather. So maybe
health,
that's
it's about not being told about what's going on and not being able to get information. Yeah, definitely.
So it does show up a lot of stuff that other outcome measures just don't actually ask that question.
Yeah,
I guess they don't.
Yeah.
So, yeah.
I mean, and it's focused on what people themselves have said is important. So I mean that's the thing that to me is most important about them, is that they really are about what people themselves in those situations find important in their lives. And obviously they're small samples because it's qualitative, but I think in terms of sort of typicality, they're relatively robust, I think.
I have a small clarifying question. So when you showed the valuation of the sort of end of life measure, and there were some surprising results that like the physical functioning wasn't as important as other things. I was just wondering what sample was used to generate these values.
Yeah, so that's an important question. So for the end of life one, we used a general population sample, and it was a very, very large sample. It was a large online survey. A lot of people had experience of end of life. I don't know whether that was because they're perhaps more likely to complete it, but it was fairly high. The original plan with that research was to then, well, it wasn't the original plan with the research. In that research, as well as doing the general population survey, we also did a pilot Think Aloud survey with people at the end of life themselves, to try to see if we could if we could use the technique to get values from people at the end of life themselves, and that was relatively successful. But our funding application, I know Catherine's probably feeling raw at the moment in terms of funding applications as well, but the funding application for that was to actually get the value set from people at the end of life was was turned down. It's something I might retry again at some point, because I do think it's quite important that we do have values, but I also think it's, you know, it's incredibly challenging to ask these sorts of questions of people where it might not be their priority for how they want to spend their time doing this sort of work. So but we have shown it's feasible, and that people in that setting can do it. So that's an area for future research, really.
So it would be the best.
Just one quick point in there.
Yeah? Sorry, I was just quite confused.
Yeah,
so
no, it's just
because
this one. I'm just aware of the time, Katerina, and there's a quick question in the chat, because we're right on time now. So I don't know whether that's something, Joe, that you want to deal with now or have a think about. We can get back to email about that one.
Oh, yeah.
Oh, gosh. Okay, so I think
that's maybe not a one-word answer, that one.
So what you're saying is that if people are mostly capable, are they sort of adapted to see themselves as being fully capable? I think it's just that actually it doesn't I think it's just that being mostly able to do these things is not actually that different from being fully able in people's minds. It's when you really can't do something that it really makes a big impact on your life. I hope that sort of captures what you're saying.
Yes, it does. I don't know if my audio is coming through.
Yes,
it is.
Okay, yeah, because I was thinking about the fact that we do live in a society where people have limitations in their capability anyway. So if you put something out for like a public vote, it's very likely that people are going to use their reality to gauge what really matters. And if most people are mostly capable anyway, then for them, mostly and fully is more or less the same thing. So you may not really see as much of a shift on that front, but once it drops beyond the mostly, then it really starts to bite. That's kind of
I think that is the case, actually. That if you have big drops in any one of these things, then it can make a big impact on your life. So the value drops much more.
Yeah.
So Katerina's just asked, could mostly and fully be collapsed? That happens in some of the measures, doesn't it?
Well, so essentially that when I talked about that sufficient capability, that is essentially what happens with that, because so Phil Kinghorn did some work on this, some exploratory deliberative work with members of the public, and to try and work out actually where people thought it was important to concentrate resources in terms of those capabilities. And what they said was that as long as people were at the mostly level, that was good enough. And so actually we don't need to put resources into moving people from mostly to fully. So the equivalent in EQ5D might be, you know, that if people are at level 4, actually we shouldn't put any resource into moving them to level 5. We should just focus on the people who are below. So that's what that sufficient capability, that's exactly what that sufficient capability approach tries to do.
Yeah, but in lots of analysis for outcomes, you just flick it to a 0, 1 anyway, don't you? With the 4 or 5 at the top and the ones at the bottom in the 0 section. For resource allocation, they often do that, I think.
Yeah.
I've just noticed the time, so I have to wrap up. My job today is to watch the clock. Joe, thank you very much indeed. That's a great talk. It's recorded. It goes onto the website. We do edit it, and it then goes onto the website where there's lots of other talks that have happened, and you know, so there's the Simplifying Health Economics video series, which Valerio and Lewis did. So if you're interested, but thank you very much, Joe, for coming along today. And hopefully we'll see you in person at some point. Thank you to everyone who attended. I know I've gone over time, terrible chairing, and some people have now left, so I apologize. But if you're watching the recording, thank you very much for attending, everyone. And we'll see you all soon, and we'll be in touch soon with more information about everything. So thank you all very much. Bye.